Ataxia in an adult, the differential diagnosis. The first thing we want to be sure of is that we are dealing with ataxia at all. The history and examination will help us to exclude other causes of unsteadiness, such as a sensory peripheral neuropathy with loss of proprioceptive feedback or dorsal column disorder, both producing so-called sensory ataxia, or ataxia due to loss of vestibular function from aminoglycoside ototoxicity. And patients may suffer falls because in fact they are suffering from something else, for example a Parkinsonian condition with poor postural reflexes, or they may have difficulty in walking because of an acquired apraxia of gait, as is seen in severe cerebral small vessel disease or frontal lobe dementias. But we are focusing here on ataxia attributable to dysfunction of the cerebellum or its brain-stem connections. Usually, unsteadiness of walking gait ataxia will be present with a broad-based gait and a tendency to veer or lurch. During Romberg's test, usually they will sway only a little more with their eyes closed compared to open, so Romberg's test is in fact negative, unlike with sensory ataxia or in the avestibular patient. The cerebellar patient is unable to walk tandemly without assistance. This may be mirrored by he or she in ataxia when we test them on the couch. The upper limbs may or may not demonstrate similar involvement. We will pay particular attention to the voice, listening for slurred speech which may have an altered pattern of timing and modulation, so-called ataxic dysarthria. It can be difficult sometimes to distinguish ataxic speech from spastic or pseudobulbar dysarthria, or from the wet dysarthria of myasthenia gravis. Not all cerebellar syndromes result in nystagmus. When it is present, it is usually gaze-evoked and not present in the prime position, beating in the direction of horizontal gaze. Pursuit eye movements may also be broken. After the history and examination, we are happy that a cerebellar syndrome is indeed present. Now we must consider the possible causes, and our thoughts there will depend heavily on how fast the ataxia has come on, how old the patient is, whether the examination shows significant laterality or asymmetry, suggesting a focal structural cause, or not, and whether other family members have been affected. For a patient presenting with a fairly symmetrical, generalised cerebellar syndrome, the speed of onset tells us quite a lot. Hyperacute causes, such as stroke or hemorrhage, we will assume we will identify easily on clinical and imaging grounds and not discuss further here. In cases of a very rapid deterioration, especially with obtundation, cerebellar signs and ophthalmoplegia, or new onset of nystagmus such as upbeat nystagmus, we should always cover the possibility of Wernicke's encephalopathy before imaging, which will occur in a thiamine deficient alcoholic patient, for example. Fortunately rare, but potentially devastating if left untreated. Onset over days to a few weeks is unusual for a fairly symmetrical generalised cerebellar syndrome. There we must consider the Miller-Fisher syndrome, classically the triad over a few days of acute ataxia, areflexia, and internal and external ophthalmoplegia, which often becomes complete, ultimately with good recovery. Or a post-infectious cerebellitis seen more commonly in children but also occurring in adults, for example following or during viral infections like EBV or varicella zoster virus. A subacute cerebellar presentation is well recognised in sporadic CJD, as well as the rarer variant CJD, but progressive cognitive features and widespread myoclonus usually make the diagnosis of those primary diseases clearer. Paraneoplastic syndromes, including cerebellar presentations, can be surprisingly acute in their speed of onset, which may mislead. Even if there are no obvious clinical pointers such as rapid weight loss, an occult malignancy should still be considered in any case of a rapidly progressing ataxia. The anti-Yo syndrome is the classic example. Whilst we would undertake testing for paraneoplastic autoantibodies in the right circumstances, the results may not be available in time to influence our initial management, and a negative result would not rule out the possibility of a paraneoplastic syndrome because the sensitivity of the screening is relatively low. Systems examination, basic bloods and a chest x-ray would be quickly followed by a CT chest, abdomen and pelvis, and where relevant, mammography and breast, ovarian or testicular ultrasound. If nothing was uncovered there, the decision would then be taken to arrange a whole body CT PET if there was still clinical suspicion. A patient or their relatives may underestimate how long the unsteadiness has been creeping up on the patient. It may have been there for years rather than months. Alcohol, a major cerebellar toxin worldwide, has to be considered right up front, especially if intake has been excessive for a long time. But many people drink more than they should. We must not fall into the trap of blaming alcohol in the cases where it is not relevant. Likewise, medications such as amiodarone, phenytoin and other medications, which when taken for long enough can cause cerebellar toxicity, should be relatively easy to identify from the drug chart. Blood tests will exclude quickly vitamin B12 deficiency or severe hypothyroidism. Ultimately, for many with a late onset cerebellar degeneration, we will not be able to assign them an etiological name for their illness. Many of those may be genetic without identifying the relevant gene. In taking the family history, we should make sure about asking about siblings, parents, aunts, uncles or perhaps cousins, and whether they had any symptoms resembling the patient's or suffered from alternative potentially relevant neurological conditions such as a movement disorder or dementia. This might point towards an autosomal dominant cerebellar ataxia. The family history may be negative, but consanguinity might be elicited, making a recessive inherited cause much more likely. I'm going to talk a little bit about the genetic causes of adult onset ataxia next.